I want to start today with a clinical mystery. It's a case study that's derived from one of our primary texts for this deep dive, Katzung's Basic and Clinical Pharmacology. And honestly, it paints a picture that is terrifying specifically because of how mundane the whole setup is.
It really is. It's the
Yeah.
kind of scenario that, walks into an emergency room every single day, anywhere in the world.
Yeah.
But the biology happening underneath the surface is just incredibly complex.
So picture this. A 40-year-old woman comes into the ER. She is visibly distressed. She's disoriented. She's shaking, tremors in her hands, and she's vomiting. But the thing that immediately tips off the triage doctors is her eyes.
The sclera,
Right. The whites of her eyes are bright yellow. She's jaundiced.
which for any clinician is an immediate flashing red light for liver failure. The engine light isn't just on, it's screaming at you.
Yeah. Exactly. So they stabilize her and they ask the obvious question, what did you take? And she admits to taking a handful of pills 2 days earlier. But here's the catch, and this is why we're talking about it. It wasn't some exotic poison. It wasn't an illicit street drug. It was a cocktail of 3 very, very common FDA-approved prescriptions.
Okay, so what was in the mix?
It was Lorcet, which is a combination of hydrocodone and acetaminophen.
Okay, a common opioid painkiller with Tylenol.
Right. Then there was Soma, which is a muscle relaxant, carisprotal,
Mm-hmm.
and Cymbalta, an antidepressant, duloxetine.
A painkiller, a muscle relaxant, and an antidepressant. I mean, on paper, these are standard medications. Millions of people take these drugs every day. But inside her body, they created a perfect storm.
The lab results were just catastrophic. Her liver enzymes, the AST and ALT, they were through the roof. We're talking in the thousands. Her kidneys were compromised. Her blood sugar was dangerously low. So the core question we are trying to answer in this deep dive is simple, but it's also incredibly profound. How did a combination of approved, common, healing drugs turn into a chemical weapon inside her body?
And the answer to that isn't just toxicity. It's not that simple. The answer lies in the invisible machinery that keeps us alive every day. The answer is drug metabolism, or I think more accurately, we should call it biotransformation.
And that is our mission today. We are exploring the hidden chemical factories inside our cells. To do this, we've synthesized 2 absolute titans of the pharmacology literature. We have Katzung's Basic and Clinical Pharmacology, specifically the chapter on drug biotransformation, which gives us that clinical scaffolding, the what happens to the patient.
And then to get under the hood, we have the drug metabolism chapter from Goodman and Gilman's The Pharmacological Basis of Therapeutics. And that source, that's going to give us the molecular depth, the physics, and, the evolutionary history of why these enzymes behave the way they do.
So by the end of this deep dive, you're going to understand why the liver isn't just a filter, it's a chemical editor. And sometimes, like in our case study, it's an editor that makes a fatal typo.
That is a fantastic way to frame it. I really like that.
Let's start at the very, very top. We usually hear metabolism and we think of, burning calories or maybe digesting a burger. But in pharmacology, metabolism means something completely different, doesn't it?
Completely different, yeah. In this context, metabolism is a defense system. It is a sophisticated chemical firewall that's evolved to handle what we call xenobiotics.
Xenobiotics. Okay, break that word down for us.
It comes from the Greek. Xeno meaning stranger or foreign, and biotic meaning life. So stranger biochemistry. This system didn't evolve for pharmaceuticals. Pfizer and Merck didn't exist 2 million years ago. This system evolved because our ancestors ate plants.
And plants don't really want to be eaten.
Exactly. Plants are chemical warfare factories. They are full of alkaloids, terpenes, and all sorts of toxins designed to punish any animal that tries to eat them. So we needed a way to neutralize those chemical weapons. Today, we use that same ancient machinery to process hydrocodone and ibuprofen.
So what you're saying is we're running new software, all these modern drugs on very, very old hardware.
Precisely. And that mismatch is where the danger so often lies.
Okay, but before we get into the enzymes and the chemistry, we have to address a really fundamental physics problem. The sources call this the lipophilicity trap. This was a huge aha moment for me reading through Goodman and Gilman. Why do we need to metabolize drugs at all? Why can't we just pee them out like we do with excess salt or vitamin C?
This is the fundamental tension of pharmacology.
Yeah.
To design a drug that works, say, something that needs to get into your brain to treat depression, or into a cell to stop pain, that drug usually needs to be lipophilic.
Lipophilic, meaning fat-loving.
Right. It needs to be hydrophobic or water-fearing.
And why is that?
It's because of the architecture of our own cells. Every single cell in your body is wrapped in a membrane, and that membrane is a lipid bilayer. It's essentially a bubble of fat. If a drug is water-soluble, it's like throwing a water balloon at a brick wall. Just bounces right off. It can't get in to do its job.
So drug developers intentionally make drugs greasy. They make them oily so they can slip through that fatty membrane and reach their targets inside the cell.
Exactly. If you want a drug to cross the blood-brain barrier, it better be greasy. But here's the catch. The kidney, our main waste disposal unit, is essentially a high-tech water filter.
It runs on water pressure, basically.
It works by filtration. Blood goes into the glomerulus, and water and small molecules get filtered out into what will become urine. But the kidney tubules, these little pipes that carry the urine away, they're also lined with cell membranes. They're lined with fat.
Ah, okay, I see where this is going.
So if that greasy, lipophilic drug molecule ends up in the urine, it looks at the cell wall of the kidney tubule and says, hey, I can cross that. And it just gets reabsorbed right back into the blood.
It enters a loop. It can't escape.
A continuous loop. If we didn't have metabolism, lipophilic drugs would be reabsorbed by the kidney over and over and over again. They would never leave the body.
Goodman and Gilman mentions a terrifying example of this involving thiopental. That's an old anesthetic, right?
Yes, an old school barbiturate. Thiopental is extremely lipophilic. That's why it works so fast. It just shoots right across the membranes and into the brain to knock you out.
Yeah.
But if we didn't have enzymes to break it down and make it water-soluble, the calculations suggest its half-life would be, well, insanely long.
How long are we talking about?
Without metabolism, a single dose of thiopental could arguably stay in the body for years.
Years from one surgery.
Potentially. I mean, you'd effectively be anesthetized indefinitely. So the mission of biotransformation is actually really simple. Take this grease-loving hydrophobic molecule and chemically beat it up until it becomes water-loving or hydrophilic.
So once it's water-soluble.
Once it's water-soluble, the kidney can trap it in the urine and flush it away for good.
So metabolism isn't just breaking stuff down. The goal is making stuff wet.
That is the most scientifically accurate, simplified definition I think I've ever heard. Yes. Yeah. It is rendering the molecule capable of solution in water.
Okay, so we know why it happens. Now let's talk about where. We always talk about the liver. It's the celebrity organ of metabolism.
And for very good reason. It is the metabolic clearinghouse.
Yeah.
And this brings us to a concept that's absolutely central to pharmacology, the first pass effect.
Right. This is all about geography, isn't it?
It is. When you swallow a pill, it doesn't just go straight to your heart or brain. It goes down the esophagus into the stomach and it dissolves. Then it moves to the intestine where it gets absorbed into the bloodstream.
Okay.
But the blood vessels draining the intestine don't go to the general circulation. They all funnel into one massive vessel, the portal vein.
Which leads straight to the liver.
Right. It's like a TSA security checkpoint.
Yeah.
Before anything from the outside world, your food, your drugs, your toxins, is allowed into the main systemic circulation, the liver gets the first chance to inspect it and, in many cases, to destroy it.
But Katzman points out something really interesting here that I think gets missed. It's not just the liver doing the work. The intestine itself is a major player.
This is so crucial, and it's often overlooked. The lining of the small intestine, the cells are called enterocytes, is packed with these same metabolizing enzymes. In fact, for some drugs, the intestine actually destroys more of the drug than the liver does. It's the absolute first line of defense.
So the drug has to run a gauntlet. It has to survive the enzymes in the intestinal wall, then survive the liver just to get into the blood to do its job.
Exactly. And then there's a third player, which, I feel like is getting a lot more attention recently in the literature, the microbiome.
The so-called forgotten organ.
Right.
Yeah.
We have trillions of bacteria living in our gut, and they have their own enzymes. And importantly, they do different kinds of chemistry than our cells do. Human liver enzymes generally love to oxidize things, add oxygen. But bacteria, they live in an anaerobic environment with no oxygen, so they love to reduce things, remove oxygen or add hydrogen.
Katzman mentions a fascinating interaction here with digoxin, the heart failure drug.
Yes, this is a classic board exam question, but it has very real-life implications. A certain percentage of the population has gut bacteria that just love to chew up digoxin. So imagine a patient who is stable on their digoxin dose. It's calibrated perfectly for them.
Okay.
Then they get a nasty sinus infection, and their doctor prescribes a strong course of antibiotics.
The antibiotic kills the sinus infection, but it also nukes the gut bacteria.
Right. Collateral damage. And suddenly, the workers that were breaking down the digoxin in the gut are gone. And the digoxin isn't broken down anymore, so much more of it gets absorbed into the blood than usual.
And the patient gets digoxin toxicity.
Exactly. They get arrhythmias, nausea, visual changes. Seeing yellow halos around lights is the classic sign.
Hmm.
And the doctor might be baffled. I didn't change your heart medication dose? No, but you changed the ecosystem that processes it.
That is wild. It really emphasizes that we aren't just a single organism, we're a walking ecosystem.
100%.
All right, let's get into the machinery itself. This is the heavy chemistry, but I want to try to keep it conceptual. The sources describe this process in two phases, phase 1 and phase 2. And I love the metaphors they use here. It's like a manufacturing or maybe a demanufacturing line.
It really is. Let's start with phase 1. This is often called functionalization. I like to think of it as the cell creating a handle on the drug molecule. Yeah. Remember, most drugs are these smooth, chemically stable, lipophilic spheres, metaphorically speaking. There's nowhere to grab onto them. They're slippery. Phase I enzymes come in and use chemistry oxidation, reduction, hydrolysis to blast a little hook onto the molecule. Usually this is an oxygen atom or a hydroxyl group.
Just so now the molecule has a sticky spot, a reactive spot, a chemical handle.
Exactly. Now sometimes that little change is enough to make it water soluble and the kidney can excrete it. But usually phase 1 is just the setup. It's preparing the drug for the heavy lifting, which happens in phase 2.
And phase 2 is conjugation.
Right. To conjugate means to join together. This is where the cell takes a massive, pre-made, water-soluble molecule, like a sugar molecule called glucuronic acid or sulfate group, and chemically welds it onto that handle that was created in phase 1.
So if phase 1 is creating the hook, phase 2 is attaching a giant, heavy, water-soluble anchor to that hook.
That's a perfect analogy. That anchor is the conjugate. It is large, it is bulky, and crucially, it is extremely polar and water-soluble. Once you attach a glucuronide molecule to a drug, that drug is never getting back across a cell membrane. It is destined for the toilet.
And usually this whole process inactivates the drug, right? Phase I sets it up, phase 2 knocks it out.
Usually. But pharmacology is the science of exceptions, and Ketsun points out that phase 2 doesn't always come second.
Wait, really? Phase 2 can happen before phase 1?
It can. The nomenclature is historical. It's not strictly chronological. The classic example is isoniazid, the tuberculosis drug. It gets acetylated, which is a phase 2 reaction first, and then it gets chopped up by phase I enzyme. So phase I and 2 refers to the type of chemistry, not necessarily the order.
Okay, that's a really good distinction to make. Now, we have to talk about the absolute star of the show, the enzyme system that does almost all of this phase I work, the cytochrome P450s.
The CYPs, the absolute celebrities of the liver.
Goodman and Gilman gets very historical here, and I love this detail. Why on earth are they called P450? It sounds like a car model or a spaceship or something.
It does. It comes from the early days of biochemistry, back in the mid-20th century. When researchers ground up liver cells and exposed these enzymes to carbon monoxide, they noticed the mixture absorbed light at a very specific wavelength, 450 nanometers.
So it was a pigment that absorbed light at 450, P450.
Exactly, and the name just stuck. But what they are is a huge superfamily of enzymes that all contain heme.
Heme, as in hemoglobin, like the stuff in our blood.
The very same molecule. Iron is the magic element here. These enzymes use that iron atom at their core to activate oxygen and smash into drugs. And they're ancient. Every kingdom of life has them. Plants, animals, fungi, bacteria.
Humans have about 57 different CYP genes, I think, but the sources say we really only care about a handful for drug metabolism.
Right. We categorize them into families and subfamilies. So you'll see names like CYP1, CYP2, and CYP3. These are the workhorses. And out of those, there is one absolute MVP. If you only remember one enzyme from this entire conversation, it has to be CYP3A4.
CYP3A4. This one enzyme metabolizes something like, 50% of all drugs on the market?
Over 50%, yeah. It is the heavy lifter. It's found in huge amounts in both the liver and the intestine. And the reason it's so important and so problematic is that it is incredibly sloppy.
Sloppy? That doesn't sound very scientific for an enzyme.
In this context, it's a compliment. Most enzymes in the body are like a lock and key. They fit one specific molecule perfectly. Insulin receptors bind insulin, period. They don't bind anything else.
Yeah.
But CYP3A4 is promiscuous. It is a massive, flexible, active site that can accommodate thousands of different shapes and sizes.
Which makes sense from an evolutionary perspective, right? We didn't know the toxins our ancestors would be eating 100,000 years ago. We couldn't have a specific gene for every possible berry or root. We needed a general-purpose shredder.
Exactly. It's a flexible defense system. The operating principle is basically, if it looks weird and greasy, destroy it. But in modern medicine, that sloppiness leads directly to drug interactions. because if you take two drugs that both need to use the CYP3A4 shredder, they have to compete for the machine,
The traffic jam.
the traffic jam. And that brings us to what is arguably the most clinically dangerous part of this entire topic, the variables.
This is section 3 in our outline, why dose X kills patient Y, because this whole system isn't static. It changes based on what else you're taking, what you're eating, and even your own DNA. And we have two main ways this goes wrong, induction and inhibition.
Right. Let's start with induction. This is the ramp up.
So induction is when the liver actually makes more of these enzyme proteins.
Yes.
Yeah.
And to understand this, we have to look at the mechanism that Goodman and Gilman described so well. It involves these things called nuclear receptors. Think of them as sensors floating around inside the cell's cytoplasm. They have names like PXR, which is the pregnanax receptor, or CRR, the constitutive androstenedione receptor.
And what do these sensors do?
They are sentinels. Their job is to detect the presence of foreign chemicals. When a certain drug binds to PXR, the receptor travels into the nucleus of the cell, latches onto the DNA, and literally hits the on switch for the CYP genes. It sends a message to the cell's machinery. We are under attack by foreign chemicals. Build more shredders now.
So the cell physically synthesizes more enzyme proteins from scratch.
Yes, and because protein synthesis takes time, you have to transcribe the RNA, translate it into protein, fold it correctly. Induction isn't instant. It has a lag time. It might take a few days or even a week to fully ramp up.
What's the classic clinical example here? The sources all mention St. John's wort.
St. John's wort is the poster child for this problem. It's an herbal supplement people take for depression. It's available over the counter, so people assume it's harmless, but it is a potent activator of that PXR sensor.
So you take St. John's wort, your PXR goes crazy, and your liver starts building a massive amount of CYP3A4.
Exactly. Now, let's say you're also taking an oral contraceptive, the pill, or maybe you're taking cyclosporine to prevent rejection of a kidney transplant. Both of those drugs are metabolized by CYP3A4. Suddenly, you have triple the amount of enzymes chewing them up.
So the birth control pill just gets destroyed before it can even work.
And you have an unintended pregnancy. Or, in the case of cyclosporine, your body starts to reject the transplanted organ, all because an herbal tea told your liver to build more enzymes.
That is genuinely terrifying because the patient usually won't even think to mention the St. John's wort to their doctor. They'll just say, it's just a supplement.
Exactly. And it's not just failure of the other drugs. Some drugs can induce their own metabolism.
Carbamazepine.
Yes, the seizure medication. This is a really tricky one for clinicians. You start a patient on a dose, and it works great. The seizures stop. But 2 or 3 weeks later, the seizures come back. Why? Because the carbamazepine itself triggered the liver to build more enzymes that are designed to destroy carbamazepine.
It effectively dug its own grave.
It did. You have to keep increasing the dose over time just to stay in the same place. It's a constant chase.
Okay, that's induction. The ramp up.
Right.
Now let's talk about the opposite, which I think is even more common in the clinic. Inhibition. The roadblock.
Inhibition is much faster. It happens pretty much immediately. And the most famous story here, as you mentioned, involves breakfast. The grapefruit.
I feel like everyone knows don't eat grapefruit with your statins, but they don't know why. Is it the acid or something?
No, it has nothing to do with acidity at all.
Yeah.
Grapefruit juice and also pomelos and Seville oranges, they contain specific chemical compounds called furanocoumarins.
Furanocoumarins.
These are nasty little molecules. They are what we call suicide inhibitors of CYP3A4.
Suicide inhibitors, that sounds incredibly dramatic for a fruit juice.
It is chemically dramatic.
Okay.
What happens is the furanocoumarin molecule enters the active site of the CYP3A4 enzyme. The enzyme starts to metabolize it, but in the process, the furanocoumarin turns into a highly reactive species that forms a covalent bond with the enzyme. It essentially welds the machine shut.
It physically destroys the enzyme.
Permanent destruction. The enzyme is dead. The cell has to build a completely new one from scratch to replace it.
Okay, so walk me through the clinical consequence. I drink a big glass of grapefruit juice at 8:00 a.m., and I take my Lipitor, which is a torvastatin, at 8:05 a.m.
Okay, so normally the CYP3A4 that's sitting in the wall of your intestine would destroy maybe 90% of that Lipitor before it even gets to your blood. That's that first pass tax we talked about. But the grapefruit juice has just carpet bombed your intestine and destroyed all the CYP3A4 guards at the gate.
So the gates are wide open.
Wide open. Instead of only 10% of the drug getting into your circulation, maybe 100% of it gets in, you have effectively given yourself a 10-fold overdose just by drinking a glass of juice with your pill.
And for a statin, that can cause rhabdomyolysis, muscle breakdown, kidney failure.
Exactly. All because of a fruit. And the effect can last for days because, remember, your body has to synthesize completely new enzyme proteins to replace the dead ones.
It's amazing how sensitive this whole system is. We've talked about diet, we've talked about other drugs, but sometimes the variable isn't what you take, it's who you are, your genetics.
This is the field of pharmacogenomics. This is the genetic hand you're dealt. And the most famous example here is the enzyme CYP2D6.
CYP2D6. Katsung has a great chart on this showing the population distribution, and it's not a smooth bell curve, it's all lumpy.
It is. Because of genetic mutations that have occurred over thousands of years, different populations have different versions of this gene. Some people have genes that produce a non-functional CYP2D6 enzyme. We call them poor metabolizers. About 5–10% of Caucasians fall into this bucket.
And why does that matter for a common drug like codeine?
This is the tricky part because it's a bit counterintuitive. Most people think codeine is a strong painkiller. It actually isn't. Codeine itself is a very weak drug. It's what we call a prodrug. It doesn't do much for pain until the liver, specifically CYP2D6, converts it into morphine.
Wait, so when you take a codeine pill, your liver is actually turning it into morphine inside your body?
Exactly. The liver is the factory that activates it. So now imagine you are a poor metabolizer. You lack a working CYP2D6 enzyme.
You take the codeine, but it never turns into morphine.
Right. You get zero pain relief. You sit there thinking, Doc, this medicine is garbage. And the doctor, who doesn't know your genetics, might think you're drug-seeking because you keep asking for more pain medicine, but it's just your biology.
But then there's the other side of that spectrum, right? The ultra-rapid metabolizers.
These people, who are much more common in North African and Middle Eastern populations, they have multiple copies of the CYP2D6 gene. Their liver is a superfactory. So they take a standard dose of codeine, and their liver converts all of it to morphine almost instantly.
So they get a massive overdose from a completely normal pill.
Yes. There have been tragic cases of children dying from respiratory depression after routine tonsillectomies because they were given codeine, and they happen to be ultra-rapid metabolizers. Their bodies turned a safe dose into a lethal overdose of morphine within just a few hours.
That is just so sobering. It really highlights that the standard dose is just a statistical average. It's a guess.
It's a myth. It's a starting point, not a destination.
There's another genetic one that the sources mention a lot, NAT2, the acetylators.
Right, N-acetyltransferase 2. This is a phase 2 enzyme we talked about. It handles drugs like isoniazid for TB and hydralazine for blood pressure. The population is split roughly 50-50 into slow acetylators and fast acetylators.
And if you're a slow acetylator taking isoniazid,
the drug isn't cleared efficiently. It builds up, it accumulates, and you get toxicity like nerve damage, peripheral neuropathy, numbness in the fingers and toes, and potentially serious liver damage.
It's incredible that we often prescribe these drugs without checking these genes first.
We're moving toward checking more often, but we aren't there yet for everyone. It's becoming more common in oncology and psychiatry, but not yet routine in your general practitioner's office.
I want to pivot now to what I think is the most dramatic part of this deep dive. Section 4, bioactivation. We hinted at this with codeine, but sometimes metabolism doesn't just activate a drug, it creates a monster.
This is the Jekyll and Hyde aspect of the liver. The goal is detoxification, but the chemistry to get there involves making things reactive. And sometimes that intermediate step is highly toxic.
And this brings us right back to our case study from the beginning. The woman with the yellow eyes, she took Lorcet, which contains hydrocodone and, crucially, acetaminophen.
Acetaminophen or paracetamol or Tylenol is the classic case of bioactivation gone wrong.
We all have this in our medicine cabinets. It's seen as incredibly safe for most people. So what happens when it goes wrong? Why does Tylenol kill your liver?
In a normal therapeutic dose, say 500 milligrams or 1,000 milligrams, about 95% of that acetaminophen goes through those safe phase 2 pathways. It gets hit with a glucuronide or a sulfate anchor, it's rendered harmless, and you pee it out.
The safe pathways.
The safe pathways. But those pathways have a limited capacity. They can get saturated. It's like a ticket counter at a concert. If too many people show up all at once, the line just stops moving.
So what happens to all the overflow acetaminophen when you take too much? Where does it go?
It spills over to the backup system, the CYP450s, specifically an enzyme called CYP2E1.
And CYP2E1 doesn't make a safe conjugate.
No. CYP2E1 oxidizes the acetaminophen into a molecule called NAPQI. That stands for N-acetyl-p-benzoquinone-ebenone.
NAPQI.
NAPQI is a chemical thug. It is a highly reactive electrophile. It is desperate to tear electrons off anything it touches. It will bind to proteins and lipids inside your liver cells and destroy them from the inside out.
But hold on, if 5% of my normal Tylenol dose always goes down this dangerous path, why aren't we all getting liver damage all the time?
Because of the hero of this story, glutathione.
Glutathione.
It's a molecule our cells make that acts like a sacrificial shield. It's a scavenger. It runs up to the NAPQI thug and says, "Take me instead." It binds to the toxin and neutralizes it, forming a harmless conjugate that you can excrete. So as long as you have enough glutathione stored in your liver, you're safe.
But in an overdose.
In a massive overdose, the production of NAPQI is enormous. You completely burn through your liver's stores of glutathione. Once that shield is gone, the NAPQI is free to start attacking the liver cells themselves. The mitochondria fail. The cell membranes rupture. The cells die. The liver literally turns into necrotic mush.
And looking back at our patient, she was taking Lorcet, which contains acetaminophen, but the case also mentioned she had a history of hepatitis C.
So her liver was already under stress and likely had less functional reserve.
And she had been vomiting and not eating well before she came in.
So her glutathione stores were likely depleted from starvation. You need amino acids from your diet to make glutathione.
And she took a handful of pills.
It's the absolute perfect storm. Her safe phase 2 pathways were saturated immediately. The drug spilled over to the dangerous CYP2E1 pathway. Her liver churned out massive amounts of NAPQI. She had no glutathione shield to stop it, and her liver began to die.
It connects every single thing we've talked about. Saturation, pathways, variables, baseline health.
It really does.
Yeah.
And it also explains why the antidote for acetaminophen poisoning is N-acetylcysteine, or NAC.
How does that work?
It's basically a precursor to glutathione. When we give a patient NAC, we're giving their liver the raw materials it needs to build more shields. If you get it in early enough, you can resupply the army and neutralize the NAPQI before it kills the liver.
That is fascinating. It's literally logistics warfare at a cellular level.
It absolutely is.
We mentioned codeine as a prodrug, but I want to touch on clopidogrel, or Plavix, because it's such a huge drug for heart patients. This is another bioactivation story, but this one is about efficacy, not toxicity.
Yes. Plavix is an antiplatelet drug. It's crucial for keeping stents from clogging up after a heart attack. But just like codeine, it is completely inactive in the pill bottle. It needs a specific enzyme, CYP2C19, to turn it on.
And here's the interaction that Katzong highlights. A lot of heart patients also have heartburn or acid reflux, so they take a proton pump inhibitor like omeprazole or Prilosec.
And omeprazole is a potent inhibitor of CYP2C19.
So you take your heartburn pill, and it shuts down the enzyme that is supposed to activate your heart pill.
Correct. The Plavix stays inactive, your platelets remain sticky, you form a clot in your coronary stent, and you have another heart attack.
And the patient thinks, but I took my Plavix every day.
But the metabolism failed. The drug was there, but the necessary biochemistry wasn't.
This leads us perfectly into Section 5, systems thinking. Because we can't just look at one enzyme in isolation. We have to look at the whole body. And one connection that really blew my mind in the reading was the link between the immune system and the liver.
Oh, this is the frontier of pharmacology. The whole biologics versus small molecules interaction space.
We usually think inflammation is just redness and swelling, but it actually changes how the liver metabolizes drugs.
Drastically. When you have a state of high inflammation like in severe rheumatoid arthritis or a bad case of COVID-19, your body releases a flood of cytokines, things like IL-6 and TNF-alpha. These are immune signaling molecules.
And what do those cytokines tell the liver to do?
They essentially tell the liver, stop processing random drugs, we are at war. Focus all your resources on making acute phase proteins to fight the infection. Inflammation actively suppresses CYP gene expression. It downregulates the production of these enzymes.
So a patient with severe, uncontrolled rheumatoid arthritis has a slow liver, metabolically speaking.
Exactly. Their CYP enzymes are downregulated. Now imagine this patient is also taking statins for cholesterol or calcium channel blockers for blood pressure. Because their metabolism is slow, the levels of those drugs in their blood might be actually quite high and stable. They're essentially induced to be poor metabolizers by their disease.
Okay, so they're at a steady state. High inflammation, slow liver, high drug levels. Now, the doctor gives them a miracle drug, tocilizumab, a biologic that blocks IL-6.
Right. It works brilliantly. The inflammation melts away, the pain goes away, the cytokine levels plummet.
And the liver
wakes up, the suppression is lifted, the CYP enzymes roar back to life at their normal, genetically determined rate.
And suddenly, the patient's metabolism speeds way up.
And those statin levels crash. The calcium channel blocker levels crash. The patient's blood pressure might spike, or their cholesterol might shoot up, not because the other drugs stopped working, but because the liver started working too well again.
That is a profound insight. Treating the underlying disease changes the pharmacology of all the other treatments.
It creates a constantly moving target. You have to anticipate these changes.
We also need to circle back to the microbiome and that enterohepatic recirculation concept we touched on earlier. Katsung goes into the mechanism of these glucuronidase enzymes. This sounds like something out of a zombie movie.
It kind of acts like one. Remember phase 2? We attach that big water-soluble glucuronide anchor to the drug in the liver. Then we dump it into the bile. And from the bile, it goes into the intestine to be excreted in the feces.
That's the plan. Flush it away.
But the bacteria that live in your gut have enzymes called beta-glucuronidases. They're essentially molecular scavengers. They see that glucuronide anchor as a sugar, as food, so they eat the anchor.
They cut the anchor off.
They cleave it right off, and suddenly the drug molecule loses its water solubility, it becomes lipophilic again.
And lipophilic things.
They get reabsorbed right back through the intestinal wall. So the drug goes back into the blood, goes back to the liver, gets conjugated again, gets dumped back into the bile. It's a cycle. Recirculation.
So this extends the half-life of the drug significantly.
It keeps the drug in the body much, much longer than you would expect based on just liver function. And this is another reason antibiotics can be so tricky. If you take an antibiotic that kills those gut bacteria, you stop the recycling process. The drug just leaves in the feces. The blood levels drop unexpectedly.
Is this why there's that long-standing debate about antibiotics making birth control pills less effective?
That's the classic theory. Estrogen from oral contraceptives undergoes this enterohepatic recirculation. So the theory is if you kill the bacteria, you lose the recycling of estrogen, blood levels drop, and maybe ovulation happens. The clinical data on how often this actually causes failure is pretty controversial, but the underlying mechanism is absolutely sound.
It's just another perfect example of how we are an ecosystem. You treat the bacteria, you affect the hormones.
Everything is connected. You can't change one thing without affecting a dozen others.
So we've covered the trap, the machinery, the variables, the monsters, and the system. What does this all mean for the clinician or even for the patient listening to this?
It means we have to move beyond the idea of one dose fits all. That concept is outdated and, frankly, dangerous.
The clinician's checklist.
Exactly. When a doctor writes a prescription, they aren't just handing over a molecule. They're introducing a new variable into an incredibly complex dynamic system.
So they need to check the traffic?
Are the pathways saturated? Is this patient already taking 3 other drugs that all want to use CYP3A4? Is there going to be a traffic jam?
They need to check for roadblocks.
Is there an inhibitor on board? Is the patient a big fan of grapefruit juice? Are they taking an antifungal medication like fluconazole?
They needed to check the engine.
How is the liver function? Is the patient 80 years old with a smaller liver and less blood flow? Or is it a neonate whose enzymes haven't even fully turned on yet? What's the baseline organ function?
And the genetics, the hardware itself.
Is this patient from a population known to have a high frequency of poor metabolizers? Is there a family history of unusual drug reactions?
It sounds exhausting, honestly, to think through all of that for every single prescription.
It's complex. But that's why pharmacology is a science, not just a lookup table. It's about constantly balancing safety versus efficacy. If metabolism is too fast, you get therapeutic failure. If it's too slow, you get toxicity. And if it goes down the wrong path, you get catastrophic organ damage.
It's always a search for the Goldilocks zone.
Exactly. You are always trying to find that zone for that specific patient.
I want to leave our listeners with a final thought from our outline because I think it sums everything up. The standard dose is a myth.
It absolutely is. It's a statistical artifact. It's based on a bell curve of enzyme activity from a clinical trial that might not apply at all to the individual sitting in front of you.
And that evolutionary perspective we started with, that we are running new software on very old hardware.
Our enzymes evolved to help us eat charred meat and bitter roots. They evolved to handle smoke from fires and toxins from plants. They did not evolve to handle synthetic opioids, statins, and antidepressants all at the same time. We're asking this ancient system to do something it was never designed for. And frankly, it's a miracle it works as well as it does.
But when it fails hard. Like in our case study.
And understanding why it fails, understanding the mechanisms, that's the key to preventing it from happening in the first place.
So the call to action for our listeners, don't just try to memorize the tables of enzymes and substrates. We have apps for that now. I don't need to memorize every single substrate of CYP2C9.
Please don't. Understand the concepts. Understand induction. understand inhibition, understand the flow from phase 1 to phase 2. If you understand the mechanism, you can predict the interaction even if you've never seen that specific drug combination before.
And go back to the source material. Katzung's chapter on biotransformation for the clinical tables and the genetic polymorphisms, and Goodman and Gilman's chapter on drug metabolism for the deep, deep molecular mechanisms of the P450 cycle.
This conversation is the map. The book is the territory. Now you have the map. Go explore the territory.
I think that's the perfect place to wrap up this deep dive into drug metabolism. It's not just digestion, it's biochemical defense. Thanks for listening.
Always a pleasure.